We have a guest from NYU. Jeff is coming from NYU. He's a resident there.
You charge him?
Yeah.
How much? Not, that's what I was going to say. Everybody doing okay? Other people at the other sites? Up there's everything.
Oh, yeah.
Well, I'm sorry I couldn't make it to the Monday's graduation dinner. I heard it went well.
Yeah. I did.
Just say when.
Okay.
We're good to go?
We're good to go.
Okay, so good morning, everybody, and whoever's out there. We got a lot to cover, and I'll get through it in an hour. If you have any questions, you can ask. If we get bogged down, we'll keep moving. So you can see the title, and what I want to spend the first part of this on is dysplastic lesions of the upper airway, particularly keratinizing dysplasia, which is totally different in terms of evaluation from cervical dysplasia, which is typically non-keratinizing. And we all need to pay attention to this, because wherever you go, this is probably one of the more common pathologies we'll see of head and neck. So particularly keratinizing dysplasia is problematic. And then I'll go into squamous cancer, what is microinvasive cancer, what looks like cancer, but it's not cancer. And then talking about variants, if we on time, then we may not finish by 8 o'clock. We could pick it up at another time. So you've all looked at epithelium, and you should know by now that everything starts in terms of proliferation from the basement or the basal zone. There's a relative basement membrane. You could see this sharp separation from the submucosa. This is the larynx. This is in particularly the vocal cord area. It's a non-keratinizing surface squamous epithelium. As you go from the basement membrane to the surface, you get maturation. Can you find mitoses in the basal zone? Absolutely. But pay attention to architecture. It's flat, and there's no dysplasia, cytomorphologic features of dysplasia, which we'll go through. I could show you pictures of the oral cavity. Some areas have keratin normally. Other areas don't have keratin normally. The locations that we identify or patients come in and present with dysplastic lesions are typically larynx and oral cavity. Why? So I'll take time to ask you questions. Why do we see early lesions, premalignant lesions, those locations, and not, let's say, in the supraglottic larynx or in the tonsil or the nasopharynx or the sinonasal tract? It's not rocket science. It's very simple. Anybody? Why do patients present with early lesions in the larynx, particularly the vocal cord, as opposed to supraglottic and subglottic and the oral cavity? Excuse me? No, it has nothing to do with the type of epithelium. Just think clinically, yeah, functional. Some keratinizing lesion, dysplastic, non-dysplasia of the vocal cord, their voice is going to change. Somebody's going to tell them, or they're going to hear it himself or herself, and they're going to go to the doctor. Presents earlier. Oral cavity, a dentist might see it. We may see it, inspecting our mouth or feel it. So patients present earlier clinically, and they go see a doctor. In the other areas, they're clinically quiescent. There's no symptoms, signs or symptoms related to an early lesion. That's why in the supraglottic larynx, the subglottic, not except for the tonsil, even the tonsil, but patients present with metastatic disease. But those lesions, until they're invasive cancer, don't present. Okay. So just some clinical pictures. That's a white lesion. It's a white lesion on the undersurface of the tongue. It is leukoplakic, right? Here's one on the vocal cord. It's white, clearly abnormal. The mucosa should look like, red and glistening. Here it's white. That's leukoplakic. Leukoplakia is a clinical term. The next one has mixed red and white. It's erythroleukoplakia. So clinically, the more worrisome lesion is anything that's red for significant underlying dysplasia. But leukoplakic lesions can be dysplastic too. So we as pathologists should not use the diagnostic term leukoplakia in our pathologic diagnosis. That's a clinical determinant. The correlate is keratosis or hyperkeratosis. Okay, so these are some of the changes, including depending if there's no keratin in the vocal cord, then you can't say hyper because there was no keratin in the first place. So it's keratosis. If it's a normally keratinizing surface and there's increase of keratin, it's hyperkeratosis. Hyperplasia is an absolute increase in the number of cells. Dysplasia, as you all know by now, even the first years have gone almost the full year in their first year, is a spectrum of cytologic changes that occurs in the nuclei and their relationship to one another. But as part of that dysplastic spectrum in the upper airway, if you remember the flat epithelium, there's changes in the shape. There's elongated redi that usually go associated with dysplasia. So this is in the, the most current published WHO book, architectural changes and cytologic changes. So we talked about the elongated redi. On the left, there are a whole bunch. I don't need to read this, but when you think about cytomorphologic changes and incorporate mitoses, so if we normally have mitoses in the basal zone, then mitoses in the mid and upper zone, particularly atypical worrisome. So in brief, what's dysplasia? It's the size and shape and chromatin changes of the nuclei. So usually if there's true dysplasia, there's an increased NC ratio, there's an increase in chromatin, so it's hyperchromatic. If you look at the contour of the nucleus, it gets irregular, it's not smooth and round. And then there's a loss of polarity, there's loss of maturation, so that normal progression to the surface becomes lost, right? And we have the epithelial to the surface. So just getting a little bit ahead of myself. In general, with some exceptions, P16 is not a determinant in the upper airway for keratinizing intraepithelial dysplasia. Think about it, keratinizing squamous cancers are typically not HPV associated. So we use P16 to help us determine, and Ki67, the extent of dysplasia. Low grade, with very rare exceptions, we can't do that in the upper airway. This is a vocal cord. Keratin came in, probably vocal cord, hoarseness or some changes. Looks in endoscopically, it's a white. You could see not only is there keratin, there are nuclei in the keratin, that's parakeratosis. And the redi are elongated, it's not flat. Do you think this is, well, I'm telling you, it's not dysplastic. So there's good orientation of the nuclei. The changes I mentioned before are not here. And here's more keratin, plus or minus nuclei. Again, elongated redi, maybe hypergranulosis, no viral changes, and cytologic atypia. So in the upper airway, there are two forms. There's the non-keratinizing or the classic, which is akin to what we see in the uterine cervix. This is decidedly uncommon, particularly in the larynx and the oral cavity. Where do we see non-keratinizing dysplasias? In the upper airway, more common if we're going to see it in an early. The first part of that is right, but you have to add another word to it. A little bit further back than the oral cavity, the oropharynx, base of the tongue. Typically, HPV cancers are non-keratinizing. Not all of them, but many of them. But we still need that kind of dysplasia. We still try to grade it mild, moderate, and severe. So this is full thickness intraepithelial dysplasia, no keratin, atypical mitoses in the mid to upper levels, no compromise of the basement membrane in this one image. This is true carcinoma in situ, full thickness, which is equivalent to severe dysplasia. This is uncommon in those locations that we talked about. So the keratinizing dysplastic lesions are much more common. And I will talk about changes in the grading, but generally we distal, tried, mild, moderate, and severe. So here's vocal cord in the lower zone. There's a loss of polarity. There are mitoses, basement membrane. There's increased NC ratio. This is mild. Active? Absolutely. We don't. It's a reactive process, and what may be the earliest form of, quote, true dysplasia. So if the patient has no use of alcohol or tobacco, and you just leave it alone, probably this is going to go away. If you see this on a frozen, it's a negative margin. Okay, mild dysplasia does not equate to a positive margin. Here's maybe a better example of mild dysplasia, lower zone, still maybe a little bit of elongated, attempt to become elongated, but architecturally relatively flat, 2/3 thickness, moderate. And this we can argue whether it's moderate or severe, but for the time being, the upper third is non-dysplastic. So in the concept of mild, moderate, and severe, you could say that this is moderate. But if I see this in a vocal cord lesion, I'm telling the surgeon to treat it as a high-grade lesion. So let's talk about dyskeratosis. That's when you have abnormal keratinization that's not on the surface. It can be individual cells, it can be keratin pearls, and part of this dyskeratotic is where you have maturation in the lower zone, which is called paradoxical maturation. So this is tangential, but you can see the intraepithelial cells, a little bit higher magnification, and then the keratin pearl and abnormal keratin invasion, considered paradoxical maturation. This is one of several features that we use. It's like diagnostic nuclei for papillary thyroid carcinoma. To say grooves only, you're going to make a wrong mistake. Diagnosis. If you just go by dyskeratosis without correlating cytologic changes that we see here, you'd be making a wrong diagnosis. You can get dyskeratosis as a reactive phenomenon. So is this moderate, severe, or carcinoma in situ? Well, you'd argue that there's still maturation, so by definition, it's not carcinoma in situ. So if it's not full thickness, it's short of full thickness, so maybe it's moderate. The problem in the upper airway is that, maybe not in this example, but as I will show you, you can get invasive carcinoma in epithelial changes that are entirely limited to the basal zone, which we might consider mild dysplasia. And in the cervix, usually there's a continuum, mild, you can have, as I will show you, drop off related to one area of the basal zone, 2/3 is benign. That's why the grading of dysplasia has been problematic. So these are examples that, where do you go with this? And can you make a diagnosis of carcinoma in situ in the absence of morphologic evidence of full thickness intraepithelial dysplasia? And what do you do with something like this, where if you look at most of this epithelium is perfectly bland, but this dysplasia here and the redi are now extending down? How much do we accept? If you use the model of non-keratinizing dysplasia, where their epithelium is limited to the lower zone, I mean, this is beyond the pale because of the architecture. One could say, well, 2/3 of this is benign, so why isn't this mild? And the reason for that is this example. If you look at the epithelium, most of it is cytologically bland, yet you have an invasive cancer growing off these elongated redi right here, in which most of this epithelium is benign. So that's why the grading has been subjective, and we're trying to take out the subjectivity. So these are just some questions. The answer is yes. You can make a diagnosis of carcinoma in situ in the absence of morphologic evidence of full thickness. But you better be very careful about how you use that term, because the clinicians understand it maybe a little bit differently than we might apply it. So in those examples that I showed you previously, in which the upper third or very top was benign, that to me is essentially carcinoma in situ, because I don't know when it's going to invade. And I want to be more aggressive in my diagnosis to forewarn the clinician that they may be dealing with an imminent invasive cancer. So yes, we'd like to be, all of us look at the case, and we can go from each one of us and get a similar diagnosis. So it needs to be reproducible and take out the subjectivity. And there's a lot of subjectivity between moderate and severe, which creates this imprecise grading system that has been published in the WHO. I'm not going to spend time on the left. In 2005, the indication was to still try to subdivide it to mild, moderate, and severe, but now we're moving to a 2-grade like Bethesda. Okay, so the Bethesda system for the uterine cervix is being applied to the upper airway. This is going to be published in the updated WHO head and neck, which should come out either at the end of this year or next year. So mild is low grade, moderate and severe is high grade. On frozen, you don't need to try to distinguish moderate from severe, because if we lump it into high grade, because the risk to invasive cancer is no different statistically from a moderate dysplasia or a severe dysplasia. So that's the rationale for making it a 2-tiered system, which takes out a lot of subjectivity and makes this a more reproducible system. And the low grade has low malignant potential, previously included mild dysplasia, and the high grade is moderate, severe, and if you see carcinoma in situ, if you think something's approaching carcinoma in situ, it becomes a high-grade lesion. So what are the etiologic factors for keratinizing dysplasia? Absolutely tobacco and alcohol. So why is a patient who has one nidus of high-grade dysplasia or even invasive cancer in the upper airway, let's say a patient comes in and has a laryngeal keratinizing invasive cancer, why is that patient at higher risk for having a second locus for either a high-grade dysplasia, let's say, or invasive cancer? So if you didn't know it, patients who are tobacco, alcohol abusers chronically, who develop a single focus of cancer, are at extreme risk of a second, much separate focus. Why do you think that is? As opposed to somebody who has an HPV cancer. If you think about it, the alcohol and tobacco doesn't go to a single spot, right? It creates a field carcinogenesis. The mutations are everywhere because that alcohol and tobacco is inhaled or ingested and is touching, if you will, everything down to the lungs or into the GI tract. So the whole mucosa is, quote, condemned. And that's why these patients are a high risk, and their surveillance needs to include evaluation of other sites. HPV, I don't understand it completely, but it doesn't create a field effect. So can HPV be linked to intraepithelial dysplasia of the upper airway? The answer is yes in select instances. I don't want to go through this. This is, been published that there is a specific oral cavity related dysplasia that morphologically is a little bit different than what I've been showing, that has recently been shown in this publication in 2013 and in this other 2013 publication to be not only P16 positive, but molecular PCR and in situ. What does that mean? We don't know, but now we've recognized it, and this is that oral cavity. Just at higher grade, you can see the cytologic dysplasia. There's also individual cell destruction or karyorrhexis and increased mitoses. And when you do P16, you can see the sharp separation of that dysplastic oral cavity area from the adjacent lower right benign epithelium. And if I did a Ki67, it would be throughout the whole. Talking about immuno, can that help us ratcheting back to keratinizing dysplasia? We already said P16 doesn't. What about Ki67 and P53? So before I show you, do you think Ki67 is going to be helpful in these keratinizing dysplasias? I get Roshan saying yes. So what if that dysplasia is entirely limited to the basal zone? Like here. So the answer is no. We already talked about you don't need full thickness dysplasia to get invasive cancer. So in those examples where there's high-grade dysplasia, but it's only limited to the lower area, the Ki67 is going to be limited to there. You're not going to get into two-thirds of full or all three layers. So it has very limited utility in those settings. Same thing with P53. Okay, what's microinvasive cancer? That's cancer that has invaded or violated the basement membrane. I know you know this, but it's worth repeating. If the dysplasia, like in the cervix, extends into endocervical glands, but in the upper airway into seromucous glands, it's still contained within the spectrum of carcinoma in situ. So invasive, whether microinvasive or not, has to violate the basement membrane. There are many definitions for this. The most important one is this one, 0.5, and it's not, if you've looked at upper airway biopsies, and I know you have, they're tangential. They're not always, going to give us the best opportunity to measure, but it's from the nearest basement membrane to the invasive cancer, no more than a 0.5 millimeter, and no angioinvasion. So if there's angioinvasion, it's not a microinvasive cancer. In invasive cancer, we look for irregular shaped nests with dysplastic epithelium. There should be, but not always, desmoplasia. Certainly, if there's invasive components in blood vessels or lymphatics, perineural, or in soft tissue, but also Keratin Granuloma. So this is cancer. By now, you probably all recognize it. If you look at the background, there's a desmoplastic stroma. The body's reacting to this as a foreign invader, which engenders an inflammatory and fibroblastic response, which is why when you look and feel cancer, it's firm. What about HPV cancers and EBV cancers? When they invade, do they do the same thing? Excuse me?
Very more inflammation, right?
Well, there's often not a host response. So that's why you may see an overrun of inflammatory cells, but no desmoplasia. So I'll show you some examples if we get that. So these biopsies of the upper airway in keratinizing lesions that are hyperplastic and dysplastic, when the surgeon takes a biopsy, they may think they're giving us a lot of tissue. But here's an example in which there's very little stroma, very little. And in the absence of stroma, it becomes impossible for us to determine if there's invasion or not. Generally, if there's invasion, the cancer will anchor to the stroma, so a biopsy won't be a neat cleavage plane of the epithelium. It'll take the stroma along with it, so we generally see that, but not always. Or in a biopsy like this, where there's very little stroma, what do? And there is dysplasia here. So is this microinvasive cancer? In general, the treatment for high-grade dysplasia and microinvasive carcinoma is about the same. So we don't compromise ourselves if we don't make an absolute diagnosis. So what do we do with this? Is this enough? There's dysplastic epithelium. There's only a little bit of submucosa, but we already know that microinvasive cancer is 0.5 millimeters. This could be that. So this is suspicious, but we need to be careful on how we evaluate these things. But the problem with this is we don't know what's below it because they didn't take a biopsy. So for me, this is suspicious for at least microinvasive cancer. And then and one thing you should always do when you leave here and you go into practice, the more you talk to your clinicians, the better off you will be. So in this example, I will call the clinician up and say, look, your biopsy is limited. There's worrisome changes for at least microinvasive cancer, but I don't know if there's not deeper invasion. Is there any clinical evidence or radiographic evidence for invasion? So don't think that you don't need that clinical information. Forget about the head and neck anywhere to help guide you. And the more you speak to the clinician, the more slack they will give us in problematic issues. So don't think you're a pathologist, you just look at the microscope and you go home for the day. You need to be interactive with your clinicians and be part of the clinical team. The more you do that, the better off you will be, and your careers will be that much better. So if you look at the upper top and the extreme right, there is dysplasia here, and then we see these granulomas in the submucosa. And this one you can already see that there's keratin in it. So this is a Keratin Granuloma. If we did a keratin, the keratin would be positive. Here's another example where you don't see the keratin. There are neutrophils. There are giant cells. You do, in that instance, it's worth doing 2 stains. Any keratin that you like. This happens to be A1, A3. Not any keratin you like. CK20 would not be advised. So CK56, CAM 5.2, A1, A3, and CD68. Because here, the keratin's positive, So we can say Keratin Granuloma, which is presumptive evidence that you have an invasive cancer. Here's another example. There's dysplasia in the epithelium. Here you see this granular, and it's not as well prepared, but there's our multinucleated giant cells. The CD68 is positive, the keratin is negative. So this happens to be a granuloma, but not a keratin granuloma. You can't suggest invasive cancer. So what?
Sorry. So that means if there is a keratin granuloma, we can call it invasive.
You could say consistent with. But the next time you look at a resection, like particularly oral cavity, and there's an invasive cancer, look there because you'll see often keratin granuloma. So that's the correlate. Often, it just doesn't happen on its own that there's keratin extruded in the absence of invasion. Okay, so factors associated with prognosis. There are many things, but I just want to remind you, because I've seen not only here, but at Mount Sinai when I sat out with the residents, not necessarily the synoptic, but in the narrative, consistently, people don't comment on the presence or absence of extranodal extension, irrespective of the cancer type. So you need to put that in and remember that that's a requirement, particularly in squamous cancer, but also thyroid cancer. And the negative is important. So 2 of 3 lymph nodes with metastatic carcinoma, extranodal extension is present or no evidence of extranodal extension. The positive and the negative, because that impacts on the next approach to therapy. Squamous cancers that have extranodal extension, like here. So here's the tumor, and this is in soft tissue. Those patients are at extremely increased risk of recurrent local regional recurrence and distant metastasis. And the surgical and medical oncologist will approach this differently. So here's another example where we play a significant part in how the patient gets managed. Okay, any questions to that point? Okay, things that look like cancer but that are not cancer. So, necrotizing Sialometaplasia. If you look here, the surface epithelium is on the bottom and a little bit here. You could see the outlines of what used to be the gland. So that's necrotic serum mucus glands. But the one thing you should pay attention to, and maybe this is not the best example, especially, well, maybe a little bit here, because this is the sialometaplastic areas, but there's a relative retention at low magnification of that lobular architecture that's normal for minor salivary glands. And when you're doing a frozen and you jump to high magnification in a patient who's got a diagnosis of cancer, who received radiation, comes back 6 or 8 weeks later for a reevaluation, and there's a little bump there. And the surgeon says, you know what, either biopsies it or schedules, because they're worried about cancer, or frozen. And we are tasked to identify whether there's persistent, because at 6 to 8 weeks it's not going to be recurrent, persistent cancer or something else. So one of the something else is this, necrotizing sialometaplasia or just sialometaplasia without the necrotic lobules. So the most important component is low magnification to see the architecture. If you see relative retention, no matter how ugly the squamous epithelium gets, it's likely not cancer. So as we go to higher magnification, this is relatively bland. You can see the, and again, I mean here, patient may have been irradiated, or maybe there was a procedure, because not infrequently when you see necrotizing sialometaplasia of the upper airway, there may have been a dental procedure or some endoscopic procedure. So there's going to be a reactive stroma that we may misconstrue as desmoplasia. And there's no hard and fast rule as what's reactive desmoplastic stroma or reactive stroma and what's cancer related. So you have to look at the lobules, the round configuration. If you wanted to, you can do a mucin or a DPS to see if there's residual mucocytes. There may not be. If I did it here, I don't see anything by live microscopy that suggests retention, but the configuration and the cytomorphology are not those of cancer. But if you looked at this, and this was the area to the upper right here, this looks malignant. And this was a very challenging case. And it was one that I had when I was in Washington. It was the sinonasal tract, and everybody in the department looked at it, and ultimately the person with the most experience felt that there was not enough to call cancer because of the configuration was retained. Here's another example. You can see the surface on top left is intact. In the submucosa, you can see the lobular configuration. If you look at these, the arrowhead is pointing to residual mucus predominantly cells, but some of this looks pretty ugly, including dyskeratosis and karyorrhexis. But if you look around it, two arrowheads are pointing to mucocytes. You can do a mucin stain or DPAS. I prefer the DPAS, at least in our labs. It's more intense red staining than when you see mucin can be very weak and problematic. So if I'm going to choose one of the two, I'm going to do a DPAS. So here's another case of pseudoepitheliomatous hyperplasia, a very florid hyperkeratotic oral cavity lesion with elongated rete. So one of the things that can come to mind is Verrucous Carcinoma. Didn't quite have the morphology. Many times in these upper airway lesions, there's fungal colonization. And when you see neutrophils in the epithelium, particularly in the surface epithelium, that often, but not always, means that there's some fungal form there. You might see it by light microscopy, you might need a GMS or a PAS, but when you see the fungus in the depth of the epithelium, like the right here, that's fungal infestation. And fungal, it's not common, but it can engender a reactive proliferation that clinically and morphologically can simulate squamous cancer. And then the classic lesion associated with pseudoepitheliomatous hyperplasia is a granular cell tumor. If you didn't pay attention to the lower part of this and just focus on the epithelium, it looks pretty nasty. But if you go back to low power, that epithelial component does not extend below the granular cell tumor. And that's one of the criteria for not jumping on a squamous cancer, even though the epithelium looks pretty malignant in the face of a granular cell tumor. And, I didn't bring another higher magnification, but these are the granular cells. So indistinct cell separation, enlarged round to oval nuclei and a granular cytoplasm that's diffusely S100 protein. These are felt to be modified Schwann cells. And when you do that S100, it may help you show that that epithelium doesn't extend below the deepest part. If it extends below the deepest part of the granular cell tumor, squamous cancer. And obviously the only other way to make a diagnosis of squamous cancer in the face of a granular cell tumor, the patient has metastatic disease, which is pretty uncommon. So squamous cancer associated with a granular cell tumor is pretty uncommon. Okay, we're going to shift to variants. Any questions? Okay, so here's a laundry list of variants, and there are more. I'm just going to focus on the top 5. We'll start with Verrucous Carcinoma, that by definition is a highly differentiated variant of squamous carcinoma. It's locally destructive, but not metastatic. Demographics are listed here. The sites are listed as well. Depending on the site, we get different clinical presentations. It is related to tobacco, smoking, and chewing. HPV, not necessarily. It impacts on the cell cycle as detailed here. So maybe a secondary player, and then the bottom bullet says that more sophisticated analysis shows that Verrucous carcinoma is not associated with HPV. So the HPV there impacts on the cell cycle, leading to immortality of the cell and progression of disease, but not a direct cause and effect. So here's a verrucoid lesion of the larynx, and the classic morphology is here. You see a very keratotic lesion, whether it's in the oral cavity or the larynx, and the way that the keratin is described, it has this layered or tiered effect, or if in Europe in particular, the church spires, you see the terminology church spire keratosis. That's just the tiered layering. The epithelium, as I will show you, is perfectly bland, but elongated, and in some instances takes on the shape of elephant feet. So you'll see in the literature elephant feet-like hyperplasia. Here's the epithelium, just to go to higher magnification. There's nothing dysplastic about it. So in general, if you see dysplasia, it generally means it's not a pure verrucous carcinoma. It may be a combined or hybrid, but it's not pure. So the hybrid cancer is one, typically if you find it, it's oral cavity, it's a mixed verrucous and conventional squamous carcinoma. And like anything that we deal with, if you have a mixed tumor, the biology is considered that of the higher grade or more aggressive tumor type. So verrucous carcinoma is invasive but not metastatic. Conventional squamous cancer is invasive and metastatic. So these hybrid cancers get treated like conventional squamous. Here's a verrucous carcinoma that in areas had dysplasia and invasive cancer, and this is clearly dysplastic. So that combination has been termed hybrid carcinoma. This is there are always exceptions to the rule. And this is a study that identified dysplasia or minimal invasion in the context of hybrid cancer and verrucous carcinoma. And basically what these authors found is that verrucous cancer with dysplasia or minimal invasion, meaning less than 2 millimeters, behave like verrucous carcinoma, as opposed to more extensive invasion, which are hybrid cancers. So this is just to show you that in limited instances, we can accept dysplasia within the context of verrucous carcinoma. So what about the biopsy diagnosis of verrucous carcinoma? We already talked very briefly about the biopsy diagnosis of minimal invasive squamous cancer. So these verrucoid lesions are very exophytic. So when the surgeons take biopsies, they may think they're giving us a lot of tissue, when in fact something like this, you could see there's hardly any submucosa. So that creates, and this is split field from the same case of multiple fragments that were sampled. And as we go to higher magnification, you could see the prominent keratosis. It's in the upper right, it's tangential. The bottom is more, appropriately sectioned, but there's no submucosa. And in other fragments, you can see what may be perceived as the features for verrucous carcinoma: the layered keratin, the verrucoid or papillary-like growth, the elongated rete, and absence of dysplasia. So let's say this is the patient's first presentation. He or she comes in with a 1 centimeter floor of mouth, lateral tongue, wherever you want, a verrucoid or leukoplakic lesion, and this is the biopsy. Is this enough to make the diagnosis of verrucous carcinoma? Anybody want to commit to that? In general, especially at the initial presentation, how do we know this is not just some reactive hyperplasia that if just excised and followed up will never recur? We don't. How do we know it's not a verrucous carcinoma? We don't. So in something like this, it's better to be conservative and just call it descriptively. Verrucoid or papillary well-differentiated squamous epithelial proliferation, which is what I do, and then we'll go through that. Even here, where there's a little bit more submucosa, there's no way to know, especially at the initial presentation. Now, if this patient has 1 or more recurrences over a few years, then this is trending towards something that's not reactive. Unless we figure out that the patient's doing something bizarre that might cause that. But in general, if it's reactive, it should not recur 1 or more times over years. So it may take a second or a third recurrence to commit to a diagnosis of verrucous carcinoma. So there's a lot of words, but what I do, and especially when I'm not convinced, is to use a descriptive terminology, suggest to the clinician to remove it all, and to follow the patient up. And if it recurs, then at that point, it's more likely verrucous carcinoma. The key differentials is conventional squamous cancer. In that hybrid cancer, we saw the dysplasia and invasion. So those features would separate it from pure verrucous carcinoma. Verrucoid hyperplasia, which could be caused by fungus, and proliferative verrucous leukoplakia, which is generally a disease of older white women. To get these plaque-like lesions in the oral cavity, and they're very challenging. Here's an example of that. The criteria applied to making a diagnosis of PVL as opposed to verrucous carcinoma is that if you draw a line, you can see the non-involved epithelium, and relatively there's no extension of this proliferation below that epithelium. You know, it can be very subjective. Some people feel that this is the earliest form of verrucous carcinoma and to manage it accordingly, which is what I think it is. So if I get a diagnosis, I might use the term PVL, but I will definitely indicate to excise it completely and treat it as if it may be the earliest form of verrucous carcinoma. So verrucous cancers need surgical excision. It's got an excellent prognosis. They don't metastasize. You may or may not be familiar with the dogma, don't irradiate verrucous carcinoma because of the high risk for transformation to a higher grade cancer. That's entirely based on a single study in the 1950s in which patients developed some higher grade display cancer 6 months after the radiation therapy, and that's virtually unheard of. So it's likely that you can irradiate patients with verrucous cancer under limited circumstances. An older person who's a poor surgical candidate who won't survive surgery, that patient could be irradiated, or if the tumor is so large that by excising it you compromise the patient's anatomy, then those are potential scenarios by which to irradiate. Papillary squamous cancer is just what it is. It's a papillary proliferation with associated intraepithelial dysplasia. And all of these variants, except for the viral associated cancers, are generally demographics are similar, older individuals, usually men, but not always. And these have been linked to alcohol and tobacco, but HPV also has been linked to this particular variant. Here's one that, you know, by now you all know what papillary, finger-like projections with fibrovascular cores. It could be more rounded or exophytic, and exophytic is another term that we can use for papillary squamous cancer. And you can see everything is dysplastic. So this is essentially carcinoma in situ with a papillary architecture, except that with this diagnosis, by definition, there is an indication that even if you don't find invasion, it's considered at least superficially invasive. Diffusely P16 positive and molecular analysis positive. Not all of these are necessarily non-keratinizing. Some of them may be keratinizing, as you see here. Had the exophytic, not quite papillary proliferation, and this one was clearly invasive. You can see the invasiveness. So it comes in the more common form, papillary non-keratinizing, but it could be exophytic, papillary, and keratinizing as well. The differential is here. Papillomas can be dysplastic, but generally or rarely dysplastic. And when they start going bad, the dysplasia is a progressive one and not what we see in papillary squamous cancer. Again, another surgical disease. The HPV ones purportedly have a better prognosis. These may metastasize local, regionally, and distantly, but they're felt to have a better prognosis than more conventional squamous cancer. Any questions as we rapidly go through the variants? I could finish on time. Spindle carcinoma. This is a variant of squamous cancer where not infrequently you won't find the squamous component, but it's a superficial lesion with a malignant spindle and pleomorphic cell population, and the variant is sarcomatoid carcinoma. The older men, typically, larynx is the most common site, particularly the true vocal cord. That has been linked to tobacco, but not to HPV, although there are reports of spindle cancers that are P16 positive. Here's a polypoid lesion of the vocal cord that's nearly compromised the airway. This one did compromise the airway. So when you see the combination of squamous cancer, whether it's intraepithelial dysplasia or invasive cancer, and a intimately associated malignant spindle and pleomorphic cell population, that's spindle cell squamous carcinoma. You don't necessarily need to do immunos, but generally we do, yeah?
Does it always usually has a component of a conventional squamous?
No, as I will show you. So the question is, does it always have a conventional squamous component? No, because often they're ulcerated. We won't see the surface. There may not be a differentiated component. And then The immunos can compound that problem, as I'll show you. So here's invasive squamous cancer and the spindle malignancy. That on the left is more spindled, on the right more epithelioid or pleomorphic. Mitoses, atypical mitoses are features that are often but not always seen. Here's a polypoid lesion of the vocal cord in which the surface epithelium may have been ulcerated, at least in the top middle, but it's attenuated. There's no dysplasia. There's no invasion. If you look at this, the vessels are oriented perpendicular to the surface, which is often seen in a reactive granulation tissue-like phenomena. If you only look at this, at this magnification, this could be granulation tissue. Except that at higher magnification in the areas there is malignant spindle cells. These lesions can be markedly collagenized and hypocellular, but when you look in between the collagen, these are high-grade malignant cells, including atypical mitoses. So immuno is not always helpful. Often the keratins are negative, and when you evaluate this, you need to do multiple keratins, not just one keratin, as well as P63 and P40. These are always Vimentin positive, 100% are Vimentin positive. So if you have a spindle lesion of the vocal cord or of the nasal cavity that's superficial, and there's no squamous differentiation, and the keratins are negative, because over 40% may be negative, P63, P40 negative, Vimentin positive, and actin positive. You want to make a diagnosis of sarcoma. A lot of people want to, but these are not sarcomas. Sarcomas are rare in the upper airway, particularly in the larynx. The most common sarcoma of the larynx is? What's the most common sarcoma of the larynx? We have one vote for leiomyosarcoma. Any other votes? We have the same person now wrong twice. Chondrosarcoma. Say chondrosarcoma? Yeah, chondrosarcoma. So common things occur commonly. That's rare. It's even rarer to get a rhabdo or a leiomyosarcoma. So a superficial lesion with morphology that's sarcoma and staining that sarcoma is still an epithelial malignancy. So the keratin may be diffusely positive, but may be very focal to absent. This is a study that still holds up. 42% were keratin negative. It'd be nice to get stains like this. And Oscar is probably the best stain. It's a broad spectrum keratin that is very helpful, even single cells. If anything's going to be positive, it's going to be Oscar. I'm showing you the best scenarios, but often it's very focal and limited. P63, which is a nuclear stain, may be focal. Here's a scenario. There's no squamous differentiation. It's sarcomatoid. It's diffusely Vimentin positive, maybe actin positive, maybe muscle-specific positive, and Desmond positive. So why isn't this a sarcoma? And the protocol is different if it's an epithelial malignancy from not. There's a nice study that did P53, which had similar expression in a true epithelial component and the non-epithelial component, which means that these are the same cell, or originating from the same cell type. So even if you don't see epithelial differentiation by light microscopy or immuno, and it's a superficial lesion of the upper airway with malignant morphology, it's still consistent with a spindle cell squamous carcinoma. These may have heterologous elements, benign and malignant, bone and cartilage. This is a Mount Sinai case about half a year ago, spindle component on the right, and an osteosarcoma, and then another one that had coexisting rhabdomyosarcoma. It wasn't a pure rhabdo. These are rhabdomyeloblasts. Desmond and MIF4 were positive. So the differentials listed here, but generally when you're dealing with the morphology I showed you, it's a spindle carcinoma. There are studies that have shown, particularly oropharyngeal, are P16 positive. Whether this mitigates the prognosis or not, it still is uncertain. These are bad tumors. They require aggressive management, surgery, adjuvant therapy, but generally the patients do bad. Basaloid squamous carcinoma, and what I'm talking about are non-HPV. You can get HPV basaloid squamous cancers too. We'll go through that. So this is a high-grade variant of squamous cancer. Often the squamous component is very limited, but predominantly this is malignant basaloid cell proliferation. Again, older men, predilects to the larynx, supraglottic larynx, the hypopharynx, the piriform sinus, and in the oropharynx, they're often but not always HPV associated, as you see here. So here's an example. There's a little bit of abrupt keratinization. So this is not normal. So that could be construed as the squamous component, but you could see this deeply invasive basaloid proliferation in which the nests fit into each other like it's a jigsaw puzzle. So hence the terminology jigsaw puzzle-like architecture. It's lobular, with or without comedo-type necrosis. And whoops, and in the upper right, you could see a trabecular pattern with some degree of extracellular hyalinized material that in limited biopsies can simulate or suggest a salivary gland tumor. So here are the lobules on the left, comedo necrosis on the right, nuclear pleomorphism, high mitotic rate, basaloid nuclei, not completely hyperchromatic, they're more vesicular, but have a basaloid look to them. Nuclear palisading may be identified. You know, now the clinicians are well aware of this, but when we were first making the diagnosis, they'd ask us, is this like basal cell carcinoma of skin? And it's not. There's no retraction artifact, but more importantly, these are mucosal lesions. Basal cancers of skin are indolent malignancies. These are lethal. On the right, you can see that reduplicated basement membrane material that we can see often in salivary gland tumors like adenoid cystic carcinoma. But if you look at the nuclei here, and I don't know if I brought an example of adenoid cystic, the typical adenoid cystic are like watermelon seeds. They're small, they're angulated, and they're extremely hyperchromatic. These and uniform, hardly any nuclear pleomorphism and hardly any mitoses. When you look at this, even in a limited biopsy, there's marked nuclear pleomorphism and a high mitotic rate. And that is a simple way of separating them out. So here's in situ component, another one in the sinonasal tract with associated invasive lobules. The squamous differentiation may be very focal with abrupt keratinization. It may be more extensive, as you see in this illustration. To the right, you may find clear cells. These are, of course, glycogen content. As you see, diastase sensitive, PAS positive material. There may be a focal spindle component, so there are variants. There may be extracellular calcification and even neural type rosettes. So generally, these are chromogranin and synaptophysin negative. Tumor loves nerves, so if you get a little biopsy that looks like, you know, reduplicated basement membrane with neurotropism, you may make a diagnosis of an adenoid cystic, which may engender a different treatment protocol as compared to basaloid squamous cancers. This is relatively, you know, these are diffusely keratin and P63 positive. And generally, neuroendocrine cancers are P63 or P40 negative or focally positive. So if you have a tumor, you're not sure, and maybe there's a little synaptophysin staining, and it's diffusely P63, that generally means you're not dealing with a neuroendocrine carcinoma. P16 in the non-oropharyngeal sites are negative, and oropharyngeal sites are often positive. The differential listed here, we talked about how to separate out adenoid cystic and small cell in particular because of the morphology and also immunostains. Basaloid squamous cancers are really aggressive tumors, particularly the HPV negative. So irrespective of site, let's say we have one in the larynx or the sinonasal tract, you still need to do P16 because some of those are HPV associated, and that may portend a better prognosis. The non-HPV tend to be deeply invasive, multifocal, and widely metastatic, including lymphatic or lymph nodes and visceral sites. And the HPV positive ones have a better overall prognosis. But the last bullet is what I said before. No matter where it arises, HPV or P16 testing should be done. Okay, we're in the home stretch, and I'll try to finish in the next 6 minutes. So just a case scenario. Here's a patient who's got a T1 and T2 lateral neck mass. The thing was biopsy, FNA. Those are malignant basaloid-looking cells. Often, this will prompt a diagnosis of poorly differentiated squamous carcinoma. As I will show you, these are HPV cancers, and in fact, they're not poorly differentiated. So we need to be a little bit careful about our terminology. So that patient then has a PET CT that shows that there's not only the neck mass and now multiple foci, but the base of tongue is lighting up. So that base of tongue biopsy is biopsy. And remember, this is Waldeyer's ring. And Waldeyer's ring is an extranodal lymphoid tissue. So look at all the lymphoid component here. When you look at this at low magnification, the surface epithelium is bland. And there's nothing here that suggests an invasive cancer, which goes back to what we talked about, the absence of desmoplastic response, or maybe more of an inflammatory response. But in that deep part, there are malignant cells that are identical to the ones that were in the neck. So this is an invasive squamous cancer. There's one dyskeratotic cell here, and then there you can see a little bit of a squamous nest there. So not all HPV cancers are wholly non-keratinizing. So the CAM 5.2, I mean, at low magnification, we didn't see anything that looked worrisome except at high magnification. The CAM 5.2 is positive. These were initially called HPV-associated basaloid squamous. Well, they're called basaloid squamous cancer. So remember, there's the HPV-associated and non-HPV-associated. But what we're talking about here is a non-keratinizing carcinoma. And these are HPV-associated. So in that neck mass, if you did a P16 and it's positive, then it's a reliable predictor that the primary is in the oropharynx. And there's no correlation to the size of the primary, which could be a millimeter and a 6 centimeter neck mass. So the primary may be tiny and give rise to large neck mass. And here's the P16 on that. These are non-keratinizing cancers, and in fact, has been identified. They arise from the tonsillar crypt epithelium. They're HPV associated. The risk is going up. I'm not gonna, because we're short on time and I still have a few things to go through. The separation of HPV and non-HPV, HPV usually younger, no risk factors, non-smokers, but that doesn't hold true anymore. In fact, smoking is a adverse compounding risk factor for these HPV cancers. And even though they have higher clinical stage than non-keratinizing HPV non-associated cancers, they generally have a better prognosis because these are radio-responsive cancers. So metastatic disease of uncertain origin, and this correlates to these primary occult cancers of the tonsil and nasopharynx, is Waldeyer's ring. I don't want to spend time here about the dedicated lymphatic drainage. This is just a study from Dr. Barnes's head and neck book, which is I think no longer in publication unless he retired, unless somebody's going to pick it up. But the incidence of finding in this meta-analysis of the primary cancer was less than a third, which engenders the consideration of branchiogenic cancer. So in short, the way I was mentored at AFIP is that there's no such thing as a primary carcinoma arising in a branchial cleft cyst. That if you see that cancer in that location, it's metastatic disease. You need to do P16 and EBV, as I will show you. So here's cystic metastasis, non-keratinizing metastatic cancer, P16 positive. Going back to the cell block of the original FNA that I showed you, here's the cell block, here's the P16. The primary was tiny, but it was found. Another example, just showing you that these cancers arise in the tonsillar crypt epithelium and not in the surface. So if you look at this, here's the cancer. If the biopsy, let's say a patient has a neck mass, no known primary, multiple endoscopic biopsies, if they only go to this level here, they don't see the cancer because it's sitting in the crypt epithelium. And here's the malignant epithelium, P16 positive. So one other point, carcinoma in situ is not to be used for these HPV cancers. So if you look at this, and this is crypt epithelium, it looks like it's completely confined to the surface epithelium. And you put the whole tonsil through, there's no invasive cancer that you can detect, yet the patient has metastatic disease. How do we explain that? The fact of the matter is that this epithelium has intraepithelial lymphavascular spaces. And the tumor colonizes those and metastasizes. Plus, there's no clear separation of cells. This is called reticulated epithelium. And so the concept of carcinoma in situ does not apply to these HPV cancers. So if I see this, whether there's metastatic disease or not, this to me is an invasive cancer for the reasons I mentioned before, P16 positive. These can have keratinization and still be P16. And I just want to finish up with the EBV cancers. So the nasopharynx, just to remind you, is a relatively defined anatomic location. There's no anterior wall. It's the back of the nasal septum is contiguous with the opening of the nasopharynx. It also abuts the base of skull, but just remember that the eustachian tube opens up into the lateral wall of the nasopharynx, and nasopharyngeal cancers often arise from behind that elevated ridge. It's a cartilaginous area. It's the fossa of Rosenmuller. You get a primary cancer. It may push that cartilaginous plate forward, shuts off the eustachian tube, creates a milieu for chronic otitis media that's unresponsive to antibiotic therapy, which is a classic scenario. The classification now is two types, keratinizing, non-keratinizing. Non-keratinizing is the differentiated, virtually identical to HPV, and the undifferentiated, which has been used erroneously as lymphoepithelium because the lymphoid component is benign. In this country, it's uncommon. In China, depending on the geography, it's relatively common in both pediatrics and adults. And often these present as occult primaries. They are linked to EBV. Here's a non-keratinizing carcinoma that could be P16 positive. So when you have a metastatic cancer in the neck that's non-keratinizing, just remember that morphology may go along with EBV. So if you're going to do a P16, always do an EBR. Because if it's a nasopharyngeal cancer, it'd be EBR positive, P16 negative, and the targeted therapy would be on the nasopharynx, not on the oral, targeted radiation. So here's more examples of that. And this is, it doesn't make a difference if they're nested or discohesive. Schminke and Rigaud, it has, those terminologies have absolutely no clinical import. So don't get caught up on that. So here you can see the nested growth. The cells are large, vesicular nuclei, prominent nucleoli, relative uniformity, little mitoses. And here you can see the absence of a desmoplastic response. The keratin stain is extremely helpful. In a patient with metastatic cancer of no known primary, in which you get a biopsy that looks like mixed inflammation, where's the cancer? It's all these, histiocytic looking cells in here that if you didn't think about it, you just say mixed chronic inflammation. You don't do the keratin, you miss the diagnosis. You do the keratin, you get this reticulated like pattern, and these are EBR positive. And here's a chart just separating out. The most important thing is don't get hung up on differentiated and undifferentiated. Their biology and their radio responsiveness is identical. You just need to identify it as cancer. If you could separate them out, that's fine. If you can't, you just say nasopharyngeal carcinoma, non-keratinizing type. These can look like lymphomas. They may look like melanoma. You may need to get those stains. So which is the lymphoma and which is the carcinoma? So it's just an example that you can't tell always. You can get discohesive cancers and cohesively growing lymphomas. So the keratin and leukocyte common antigen. Here's a lymphoma that looks like it's growing like an epithelial malignancy, but it was leukocyte common antigen positive. Patient with metastatic cancer of unknown primary. You look at the morphology, their mitoses. It has the similar morphology than non-keratinizing carcinoma. The far side is disconnected, okay. But it was EBR negative and P16 positive. So just to show you as we finish up that you can get cancers in the neck that are morphologically identical as EBV and HPV. So we need to do both stains. And this is just a study showing what was described as lymphoepithelial-like carcinoma, because those nasopharyngeal undifferentiated cancers that arise in non-nasopharyngeal sites are termed lymphoepithelial-like. because they have the features of that lymphoepithelioma. So what I tried to do, and ran a little bit over, is describe keratizing dysplasia. We're moving to a two-tiered system. We should use that. Our clinicians may not be familiar with that, so we need to familiarize them on what that means, not only in terms of diagnosis, but therapy. How do you diagnose microinvasive carcinoma and more deeply invasive cancer, what looks like cancer or not, and just go through some of the variants of squamous carcinoma. And we are moving towards classification of these viral tumors as what they are, HPV associated and EBV associated. Okay, any questions? Before you run off, any issues that we need to deal with residency-wise? We had a nice meeting yesterday. Some things were discussed. We need to pass those on either through the chief residents or as the new residents come in, have a discussion as soon as they come in about what our expectations and how to go about, talking about issues that might involve each person individually.
We just have to disconnect this.
Okay. I'm happy to be disconnected. If not, have a good day. Can I pull this out? Yeah.
Where's the camera? Oh, there. So, Dr. Wenig, screen the cell.